See, in final year of MBBS or during post-graduation course, one of the difficult system examination we had to face is the examination of nervous system in a patient. Okay, the examination is done on following points. Number one, higher mental functions, then cranial nerves, then motor system examination, sensory system examination, cerebellum, and at last miscellaneous like autonomic nervous system examination, meningeal signs, and skull and spine. Today I will discuss on higher mental functions. The first and foremost point on the examination, higher mental functions, and we have to know about which is controlled by it, and that is cerebral cortex. Okay, so as far as my cortex is concerned, it is comprised of 4 lobes, and I think all of you know this already. 1 frontal lobe, number 2 temporal, number 3 parietal, and number 4 occipital. So cerebral cortex comprised of 4 lobes: frontal lobe, temporal lobe, parietal lobe, and occipital lobe. Okay, so today I will discuss a very important topic which will automatically cover both physiology and medicine, and that is cerebral cortex. We are studying medicine, so I have to talk about the diseases. We can divide the disease which can affect the cerebral cortex in 3 major conditions. So cortex can be involved in 3 major conditions like disease. Number 1 is degenerative diseases, number 2 is ischemic insults or ischemia, and number 3 is demyelination. 3 kind of disease can affect cerebral cortex. Now give one example of each. Degenerative disease, yes, it is dementia, and most common cause is Alzheimer's. Very good. These topics I will cover it later. Ischemia, and known as stroke, that's a entirely different territory of vascular territory. I will discuss it later and in details. And third one is demyelination. The most common example is, yes, multiple sclerosis. So just remember this, these type of diseases can affect the cortex. So now coming to the lobes, we will first discuss frontal lobe. So frontal lobe is situated where? Anatomically, you have to remember this pinpointly. Okay, specifically frontal lobe is situated to the left of central sulcus. This is central sulcus, and this is sylvian fissure. So to the left of central sulcus and above sylvian fissure. Okay, and I forgot to mention, frontal lobe is situated on which surface? See, brain has 3 surfaces. One is superlateral, one is medial, and one is posterior, and frontal lobe is situated on superlateral surface. So frontal lobe is situated on superlateral surface to the left of central gyrus, central sulcus, and above sylvian fissure. So this is the frontal lobe. Okay, so in frontal lobe, first area I am going to discuss is motor cortex. Very important area is motor cortex. First is motor cortex. So location, it is situated, it is called area 4, and I am showing it on the picture. This is area 4 and it is present on precentral gyrus. Precentral gyrus just to the left of central sulcus. This is central sulcus and this is precentral gyrus area 4. Okay, so what is the function of motor cortex? See, 30% of corticospinal tracts originate from motor cortex, primary motor cortex. To be specific, 30% of corticospinal tracts originates from primary motor cortex. And why is it called motor cortex? Because you will need lowest amount of threshold to initiate a movement. That's why it is called motor cortex, because for other areas of brain you have to, if they want to supplement the action, you will need more forces and the threshold will be larger. So least amount of threshold is needed from this area to initiate a movement. So that's why it's called motor cortex. So as the corticospinal tracts originates from here 30%, so these are concerned with what? Fine distal movements of hands, of limbs. Okay, so yes, I am talking about physiology. Now I have to talk about medicine. So in a patient is a disease, if there is a lesion, but if you suspect a lesion on motor cortex, how will it present? See, motor cortex, lesion on motor cortex, so it will obviously involve corticospinal tract, and involvement of corticospinal tract will cause what? Weakness. Very good. Now you have to tell me, this weakness is whether it is UMN or LMN type of weakness. Say what? Yes, it is UMN type, not LMN, because LMN type weakness starts from anterior horn cell. So lesion on motor cortex will obviously affect corticospinal tract, which will cause UMN type of weakness. Now stay with me. Corticospinal tract don't descend to the spinal cord straight, it will decussate in medulla. So if right side, if the lesion is on the right side, the tracts will cross in medulla to the left side, so the weakness will be on the contralateral side. Clear? Lesion on motor cortex, corticospinal tract will be affected, it will cause weakness. What type of weakness? Human type of weakness. Corticospinal tracts as decussate in the medulla, so the weakness will be on the opposite side. So lesion on the motor cortex will cause contralateral UMN type of weakness. Okay, now another fact I have to tell you, that brain, I talked about the surface of brain, superlateral surface and medial surface and posterior surface. Okay, superlateral surface is the territory of middle cerebral artery and medial surface is the territory of anterior cerebral artery. Just remember two facts and I am going to explain it in the next slide. In continuation of the previous slide, I was talking about the vascular territory of the brain. See, this is the medial surface, and this is the superlateral surface. I talked that medial surface was a territory, medial surface is territory of anterior cerebral artery and superlateral surface is territory of middle cerebral artery. Now if you see the somatotropic representation of our body on the cerebral cortex, you can clearly see face and hands and arms and upper limbs are mostly represented on the superlateral surface. Okay, and lower limbs are represented on the medial surface of the cerebral cortex. face and upper limb on superlateral surface, lower limb on medial surface. So now just say with me, if there is a lesion on the motor cortex which is on the superlateral surface, okay, so weakness, human type of weakness which I talked about it earlier, human type of weakness which occur on which side of the body? Yes, on the contralateral side of the body, and the most affected region will be face and upper limb. Very good, because the lesion on the motor cortex and it is present on the superlateral surface. And second fact is also, if middle cerebral artery there is ischemia, superlateral surface will be affected, and also the cause and the weakness on the face and upper limb of the contralateral side. If AC is involved, medial surface will affected, and weakness will be on lower limbs. So now in conclusion we can say that if lesion on motor cortex, suppose a lesion on the right sided lesion on motor cortex, there will be a left sided type of weakness predominantly affecting face and upper limb. Okay, so that's it. So in frontal lobe we have talked about the first and major area, that is primary motor cortex, area number 4, located on precentral gyrus. Okay, now coming to the second area, then that is premotor cortex. Premotor cortex area is 6 and 8. See the on the see picture 6 and 8. This is premotor area. Okay, premotor area, and you have to know that 30% corticospinal tracts will originates from here. So 30% was from primary motor area, and rest 30% is from premotor area. Okay, so now you will be asking that, sir, what is the difference between primary motor area and premotor area? See, now I am giving you an example. See, a pen is there is a table and a pen is lying and you are sitting here. Okay, if you are having to do a fine skilled movement which does not require any kind of plan or integration, and this is something I can do just with the help of a motor cortex. You are seeing a pen lying on the table, you just simply reach it and grab it, just, and this kind of action is done by motor cortex. No need of any plan or sequence or integration. Okay, now in coming to the premotor cortex function, there is a table, there is a pen, but along with the pen there are other objects surrounding the pen. There are obstacles you have to go through about, and you are sitting it here. So now in the middle of 3-4 things I have to displace other things so that I can reach the pen. So I will need some kind of sequential understanding and organization. Here comes the premotor cortex. I think I have cleared the doubts between the functions between the premotor cortex and primary motor cortex. Primary motor cortex deal with only the action, simple action. Pen is lying there, you just reach it and grab it. Okay, there is no need of any sequential planning or integration or organization. Okay, and primary and premotor cortex there are obstacles around the objects, you want to grab it or reach it, so you have to just think, you have to organize, you have to go sequentially, you have to displace the other objects. So some kind of sequential understanding and organization will be required, and that is helped by premotor cortex. Okay, so I think I have said it very clear. Now I will go to the next slide. Now I am coming to the third and most important area, and that is frontal eye field. We have talked about the area 4, area 6 and 8, that is, and that was primary motor area. Area 4, 6 and 8 was premotor area, and to the left of the premotor area, the entire area on the frontal lobe is called the prefrontal area. Okay, and there is one small area on the prefrontal area or prefrontal cortex, and that is frontal eye field. Okay, the green mark is frontal eye field. Okay, so frontal eye field is a part of prefrontal area, and prefrontal area comprises of area 9, 10 and 11. Okay, now just stay with me, because I am going to discuss one of the very important topic you will need in medicine, you will need during examination, and you will need in ophthalmology, neuro ophthalmology, and which is very difficult to understand is otherwise. Okay, now see, as per our so as per our horizontal eye movements are concerned, there are two movements. One is saccade and other is pursuit. Saccade movement is the rapid movement and pursuit is the slow movement. Now suppose a person is entering a room and you are sitting in the middle of the room. The moment the person enters, you just give a rapid gaze on the person to see which one is it. Okay, who is it? That is saccade type of movement. Just a motion, rapid movement to notice something. Okay, now the person, after entering the room, the person slowly walking towards the room and sits on the back of the room on a bench. Okay, now you just notice during the entry, and that was second movement, and now you will start to follow him slowly to what type of activities is he doing and what position is he taking finally, and that the slow and pursuing movement is called the pursuit. Slow movement, you are following that person. So the eye movements are two types, saccades and pursuit. Saccade is rapid movement and pursuit is slow movement. So here comes the physiology. For you to look to the right side, you will need the help of left frontal eye field. Left frontal eye field. So left frontal eye field will help you to look on the right side. How? Now left frontal eye field will activate but will stimulate the right sided cranial nucleus. Sixth cranial nerve nucleus. Okay, and sixth cranial nerve nucleus will stimulate right lateral rectus, and right lateral rectus will look towards right side. Clear? Left frontal eye field will stimulate right sided sixth cranial nerve nucleus. Sixth cranial nerve nucleus will supply right sided lateral rectus, and that will help you to gaze towards right side. Okay, so now I will conclude it here. A person is having a lesion on frontal cortex, suppose motor cortex, sorry, not motor cortex, frontal cortex. Okay, right side. A lesion on the right frontal cortex. Now how will the patient will present? Number 1, as the frontal cortex is involved, so left sided UMN type weakness, mainly involving face and upper limb, left sided. And number 2, what will be the eye movement? See, the right frontal cortex is affected. So right frontal cortex means the right frontal lobe, the right frontal eye field is affected. So right eye frontal eye field affected means the patient cannot, right frontal eye field will help to look towards left side. Okay, so right frontal eye field is affected, so patient can't look towards what side? Left. So gaze will be towards which side? Right side. Okay, so which frontal lobe? The affected frontal lobe, and the gaze will be on the affected side. Here the lesion on the right side and the gaze will be towards right side. Okay, so that's it. I think I have cleared your doubts. Thank you. So till now we have discussed about the primary motor cortex, about the premotor cortex, and third the frontal eye field. Now coming to the fourth area, and that is Broca's area. Yes, it is area 44, 45 situated on inferior frontal gyrus. Yes, I am showing you on the picture. This is inferior frontal gyrus and this area will be 44, 45. Okay, so the lesion of the Broca's area, what will be the presentations? Now that will be called Broca's aphasia. It's very simple. Okay, so feature will be 1, non-fluent aphasia. Aphasia will be non-fluent. Number 2, word output will decrease. Number 3, the person will talk with difficulty. So talks with difficulty. Number 4, the speech will be telegraphic. Remember this, it can be asked in exam. Telegraphic or dysarthric. 5, pronunciations will be wrong. Number 6, another important facts, repetition is lost. But comprehension remains intact. Very important, because comprehension of the language is controlled by Wernicke's area. I will discuss it later. So this is Broca's aphasia. Just remember this, the aphasia will be non-fluent, telegraphic speech, repetition is lost, but the comprehension remains intact. Broca's area is area 44, 45 and is situated on inferior frontal gyrus. Each and everything will can come in as questions. Okay, so coming to the last slide, till now we have discussed the frontal lobe and 4 the most important areas, and that were number 1, primary motor area, number 2, premotor area, number 3, frontal eye field, number 4, Broca's area, and lastly I am going to discuss prefrontal cortex. Yes, I told you that frontal eye field was a part of prefrontal cortex, and prefrontal cortex you already know, and I already told you in the previous slide, it is area 9, 10 and 11. and it is present which side? It is present to the left of the premotor area. Yes, I am showing you it again. Precentral gyrus, central sulcus, central sulcus, precentral gyrus. This is primary motor area. This is premotor area, and the frontal prefrontal cortex will be around this side. Okay. This is 4. This is 6 and 8, and this will be the prefrontal area. Prefrontal area. Okay. So just know the functions. Just remember this will not be asked in questions thing, but can come, and if come it will be very difficult if you don't understand, if you don't have any concept. Okay, so which functions a premotor area will carry out? Number 1, personality. Number 2, problem solving, your problem solving capacity, the problem solving ability. Number 3, your intelligence. Number 4, motivation. Now most important, number 5, retrieval of memory. If I ask you that what did you take at breakfast 2 days ago, this type of question. If I ask you what type of food did you take at breakfast, but during breakfast 2 days ago, you have to search through all of your memories, and slowly you will recollect the information that I am asking you for. Okay, that is called the retrieval of the memory, and it is done by the prefrontal cortex. Okay, number 6, appropriate social behavior. So just remember 2 or 3 things. Number mostly retrieval of memory, very important, intelligence, personality, and problem solving ability. Okay, now I have to talk about one disease, because I am teaching you medicine, and if there is a disease associated with the prefrontal cortex, but when the disease prefrontal cortex will be affected, and that is Pick's disease. Pick's disease. In this, atrophy of prefrontal area happens, and it will present as akinesia, rigidity. Because see, prefrontal cortex is connected to the subcortex like striatum, part of basal ganglia. So prefrontal cortex is connected to the subcortex via one fiber, that is frontostriatal fiber. So in Pick's disease, frontostriatal fiber will be affected, prefrontal cortex will be atrophied, and what will be present as this lesson progresses, patient will present as akinesia and rigidity, something like you will read in Parkinson's. So that's it. That is the area I have talked about on the frontal lobe, superlateral surface. Superlateral surface, frontal lobe, there are 5 areas I have talked about it, and just go through it. I have tried to build a concept for you so that you can remember these things easily, because these will be asked in examination in various patterns. You will recur in physiology, you will recur in ophthalmology, you will recur in medicine, any question you can be asked in examinations of a patient. Okay, so just be ready for it and just go through it. I think you will understand it very clearly. Thank you.